What drew you to a career in surgical ICU nursing?
What drew me to a career in surgical ICU nursing is a deep-seated passion for providing critical care in high-stakes environments where patients are most vulnerable. I have always been motivated by the complexities of medicine, and the surgical intensive care unit is a place where those complexities converge, requiring a blend of technical skills, quick thinking, and compassionate care. During my clinical rotations in nursing school, I was particularly drawn to the surgical ICU because of the opportunity to make a significant impact on a patient's recovery, often following life-saving surgeries. The ability to be there for patients during some of the most critical moments of their lives, offering both advanced medical interventions and emotional support, is incredibly rewarding to me. Moreover, surgical ICU nursing is intellectually challenging, as it requires a thorough understanding of diverse medical conditions, postoperative care, and the ability to anticipate and respond to rapid changes in a patient's condition. This dynamic environment allows me to grow both professionally and personally. Knowing that I can be part of a multidisciplinary team, collaborating to provide the highest standard of care, truly drives my passion for this field. In essence, my decision to pursue a career in surgical ICU nursing stems from a desire to combine my technical nursing skills with my compassion for patients, helping them navigate critical stages of their recovery and contributing meaningfully to their healing process. Describe a challenging situation you faced in a surgical ICU setting and how you handled it. One particularly challenging situation I faced in the surgical ICU involved a postoperative patient who had undergone a complex abdominal surgery and was experiencing rapid hemodynamic instability. The patient's blood pressure began to drop suddenly, and they exhibited signs of septic shock. It was a critical moment, as we needed to act quickly to prevent further deterioration. As the primary nurse, I immediately alerted the ICU team while simultaneously starting interventions based on the protocols for shock management. I initiated fluid resuscitation and administered vasopressors as per the physician's orders to stabilize the blood pressure. Monitoring the patient's vitals closely, I prepared for potential intubation and ensured the necessary equipment was readily available. At the same time, I communicated with the surgical and critical care teams to provide continuous updates on the patient's condition. This situation required quick decision-making, effective communication, and the ability to stay calm under pressure. I remained focused on executing each task methodically while prioritizing the patient's immediate needs. Collaborating with the ICU team, we ran additional diagnostics and discovered an underlying infection that required urgent treatment. I coordinated with the pharmacy to ensure timely administration of antibiotics and other supportive care. Throughout the ordeal, I also provided reassurance to the patient's family, explaining the situation and the steps we were taking, which helped alleviate their anxiety. The patient gradually stabilized, and over the next few days, they showed marked improvement. This experience reaffirmed the importance of teamwork, critical thinking, and maintaining composure in high-pressure situations. It was a reminder that even in the most challenging moments, staying organized and proactive can make a life-saving difference. How do you prioritize patient care in a fast-paced and demanding environment? In a fast-paced and demanding environment like the surgical ICU, prioritizing patient care is essential to ensuring safety and effective outcomes. I use a combination of clinical judgment, time management, and communication skills to organize my tasks based on the urgency of each patient's condition. First, I assess patients systematically using the ABC, airway, breathing, circulation, approach, which helps me identify those in immediate need of life-saving interventions. Patients experiencing acute changes, such as respiratory distress, hemodynamic instability, or postoperative complications, receive top priority. Once critical needs are addressed, I move on to other high-priority tasks, such as administering medications on time, wound care, and ensuring that all lines and devices are functioning properly. Effective communication with the healthcare team is also a key part of my prioritization process. By collaborating closely with physicians, respiratory therapists, and other nursing staff, I ensure that care plans are aligned and that nothing falls through the cracks. I also delegate tasks when appropriate, which allows me to manage my time more efficiently and focus on patients with more complex needs. Another crucial aspect is anticipating potential complications. I regularly monitor each patient's condition for signs of deterioration, which allows me to intervene early and prevent more serious problems. In the surgical ICU, where patients can decompensate quickly, being proactive and constantly reassessing priorities is vital. Lastly, I remain flexible and adaptable. In a busy environment, unexpected situations can arise, and it's important to adjust priorities in real time. By staying organized, maintaining a calm demeanor, and being prepared for sudden changes, I am able to provide high-quality care to all my patients, even in the most demanding conditions. What is your experience with managing complex patient care needs, such as those with multiple comorbidities or following major surgeries? My experience managing complex patient care needs, particularly those with multiple comorbidities or following major surgeries, has been both challenging and rewarding. In the surgical ICU, many of the patients I care for have multifaceted health issues that require a high level of clinical expertise, attention to detail, and a collaborative approach to care. In patients with multiple comorbidities, such as diabetes, cardiovascular disease, or chronic respiratory conditions, the management of postoperative care is particularly intricate. These patients often have a higher risk of complications, such as infections, delayed wound healing, or respiratory failure. I have developed strong skills in continuously assessing these risks, implementing individualized care plans, and adjusting interventions based on the patient's evolving condition. For example, I frequently monitor blood glucose levels in diabetic patients post-surgery to prevent hyperglycemia, which can compromise recovery, and adjust insulin therapy accordingly. In addition to medical management, effective care of complex patients requires a multidisciplinary approach. I have experience coordinating with various specialists, such as surgeons, cardiologists, and respiratory therapists, to create a comprehensive care plan. Communication and collaboration are key, as it ensures that all aspects of the patient's health are being addressed simultaneously, from their surgical recovery to the management of chronic conditions. Caring for patients after major surgeries, such as cardiac, orthopedic, or gastrointestinal procedures, also involves anticipating complications and providing intensive monitoring. I ensure close observation of vitals, fluid balance, and signs of infection, while also focusing on pain management and mobilization to promote healing. In these cases, I've found that early interventions, like preventing pressure ulcers or deep vein thrombosis, are critical to improving outcomes. Overall, my experience managing complex patient care needs has taught me the importance of staying vigilant, thinking critically, and working as part of a team to deliver holistic care. This approach not only helps improve patient outcomes but also ensures that we're addressing both the immediate post-surgical challenges and the underlying health conditions that could impact recovery. How do you ensure patient safety and prevent complications in a surgical ICU setting? Ensuring patient safety and preventing complications in a surgical ICU setting requires a proactive, detail-oriented approach that balances clinical vigilance with effective communication and teamwork. I prioritize several key strategies to maintain high safety standards and minimize risks for complications. One of the most important steps is continuous monitoring and thorough assessment. In the surgical ICU, patients' conditions can change rapidly, especially following major surgeries or with complex comorbidities. I closely monitor vital signs, lab results, and any early signs of deterioration, which allows me to intervene promptly. For example, tracking hemodynamic parameters or recognizing early signs of sepsis can help prevent a crisis before it escalates. Adherence to established protocols and best practices is another critical factor. I follow strict infection control measures, such as hand hygiene, sterile techniques for catheter insertions, and regular wound care, to reduce the risk of hospital-acquired infections. I also ensure that central lines, ventilators, and other devices are managed according to evidence-based guidelines to prevent complications like ventilator-associated pneumonia or catheter-related bloodstream infections. Medication safety is a major focus in preventing errors and adverse reactions. I double-check all medications, confirm proper dosages, and stay vigilant for potential drug interactions, especially in patients with multiple comorbidities who may be on complex medication regimens. If necessary, I consult with the pharmacy or clinical pharmacist to ensure the safe administration of drugs, especially when managing pain relief or sedatives post-surgery. Effective communication within the healthcare team is crucial for patient safety. I consistently update physicians, respiratory therapists, and other team members on any changes in the patient's status. During handovers, I provide detailed reports, ensuring that incoming nurses have a clear understanding of the patient's condition and care plan. Additionally, I make it a point to involve the patient and their family in the care process, educating them on postoperative care, wound management, and potential warning signs to watch for. Lastly, I take a preventive approach by anticipating complications before they arise. This includes early mobilization to prevent blood clots, close attention to fluid and electrolyte balance, and using preventive measures for pressure ulcers. By staying proactive and focusing on early interventions, I help reduce the likelihood of complications and improve patient outcomes. Through continuous monitoring, strict adherence to protocols, clear communication, and early intervention, I work to ensure patient safety and minimize complications in the surgical ICU, maintaining the highest standard of care in this critical environment. What is your experience with managing patients on mechanical ventilation? I have extensive experience managing patients on mechanical ventilation in the surgical ICU, where ventilated patients often require critical, round-the-clock care. My role in managing these patients involves a deep understanding of ventilator settings, airway management, patient assessment, and collaboration with the multidisciplinary team to optimize respiratory support and recovery. The first step in managing ventilated patients is ensuring that the ventilator settings are appropriate for their condition. I am well versed in adjusting key parameters such as tidal volume, respiratory rate, and PEEP, positive end expiratory pressure, depending on the patient's underlying respiratory status, surgical procedure, or comorbidities. For example, in cases of acute respiratory distress syndrome, ARDS, I have experience applying lung protective strategies, such as low tidal volumes and higher PEEP, to minimize lung injury. In addition to ventilator management, I continuously assess the patient's respiratory status by monitoring arterial blood gases, ABGs, oxygen saturation, and other clinical signs like chest rise and breath sounds. I use this data to detect any signs of complications, such as hypoxemia, hypercapnia, or ventilator-associated pneumonia, VAP, which are common risks for mechanically ventilated patients. Early identification of these issues allows me to collaborate with the respiratory therapist and physician to adjust treatment plans or modify ventilator settings as needed. Another important aspect of managing ventilated patients is ensuring proper airway care. I frequently perform endotracheal suctioning to maintain a clear airway and reduce the risk of infection or obstruction. I also regularly assess the endotracheal tube's positioning and ensure that oral hygiene is maintained to prevent infections, which is essential in minimizing the risk of VAP. Strict adherence to infection control protocols is critical in this process. When the patient shows signs of improvement and readiness for extubation, I play a key role in the weaning process. This involves gradually reducing ventilator support and closely monitoring how the patient tolerates spontaneous breathing. I ensure that the patient remains stable during this period by frequently assessing their respiratory effort, ABGs, and overall clinical condition. Once weaning criteria are met, I assist with extubation, ensuring the patient has adequate respiratory function and is prepared for the transition to non-invasive support or spontaneous breathing. Throughout the entire course of mechanical ventilation, I also prioritize patient comfort and safety. This includes effective sedation management, ensuring the patient is not overly sedated or agitated, as well as using techniques like prone positioning in certain cases, such as ARDS, to improve oxygenation. In summary, my experience with managing patients on mechanical ventilation involves not only understanding the technical aspects of ventilator settings and airway care but also continuously assessing the patient's condition, preventing complications, and collaborating with the multidisciplinary team to promote successful outcomes and eventual extubation. How do you handle emergency situations, such as cardiac arrest or massive hemorrhage, in a surgical ICU? Handling emergency situations like cardiac arrest or massive hemorrhage in the surgical ICU requires a calm, focused, and organized approach to ensure swift, life-saving interventions. I rely on my advanced clinical training, quick decision-making, and effective teamwork to manage these high-pressure scenarios and optimize patient outcomes. In the event of a cardiac arrest, I follow the ACLS, Advanced Cardiovascular Life Support, protocols immediately. The first step is to initiate a rapid assessment to confirm the patient's status, checking for responsiveness, pulse, and breathing. Once cardiac arrest is confirmed, I activate the code team and begin high-quality chest compressions to maintain circulation. While continuing compressions, I ensure defibrillation is prepared if indicated, such as in cases of ventricular fibrillation or pulseless ventricular tachycardia. Simultaneously, I manage the airway by positioning or securing the endotracheal tube if needed, often in coordination with the respiratory therapist. I assist the code team with drug administration, whether it's epinephrine or antiarrhythmics, while also ensuring that intravenous access is functional for rapid medication delivery. Clear and concise communication with the team is critical to ensure that everyone understands their roles, whether it's chest compressions, medication management, or rhythm analysis. Throughout the resuscitation, I continuously monitor the patient's rhythm, vitals, and response to interventions, while ensuring that all events are meticulously documented. Massive hemorrhage situations, often seen post-surgically, require equally rapid intervention but with a focus on stopping the bleeding and maintaining hemodynamic stability. In these cases, I immediately notify the surgical team and initiate the massive transfusion protocol, which involves the rapid administration of blood products, including packed red blood cells, fresh frozen plasma, and platelets. During massive hemorrhage, I prioritize securing large bore for access, or using a central line if already in place, to facilitate fast fluid and blood product delivery. Continuous monitoring of vital signs, particularly blood pressure and oxygen saturation, helps me assess the patient's response to treatment. I also ensure that the patient's airway and breathing are stabilized, as hypovolemia from hemorrhage can lead to shock and respiratory distress. Collaborating with the surgeon is critical to determine the source of bleeding, and if needed, prepare the patient for an urgent return to the operating room. Meanwhile, I manage vasopressors to support blood pressure and prevent hemodynamic collapse. Additionally, I coordinate with the lab for rapid blood testing, including cross-matching and coagulation studies, to tailor transfusion and correct coagulopathies that can exacerbate the bleeding. Throughout both scenarios, cardiac arrest or massive hemorrhage, my focus remains on maintaining clear communication with the team, staying organized under pressure, and acting quickly to provide the highest level of care. By adhering to established protocols, staying calm, and prioritizing critical interventions, I can help guide the team through even the most chaotic emergencies and give the patient the best possible chance for survival and recovery. What is your experience with central venous catheter care and management? I have extensive experience in the care and management of central venous catheters, CVCs, a critical aspect of patient care in the surgical ICU. CVCs are commonly used for administering medications, fluids, blood products, and for hemodynamic monitoring in critically ill patients, so their proper management is essential to prevent complications such as infections, thrombosis, or catheter malfunction. The first step in CVC management is ensuring strict aseptic technique during insertion and care. When assisting with the insertion of a central line, I ensure that all sterile precautions are followed, including sterile draping and the use of full barrier precautions. Once the CVC is in place, my priority is to maintain sterility to prevent catheter-related bloodstream infections, CRBSIs. I follow evidence-based guidelines for dressing changes, which include using sterile gloves, a chlorhexidine-based antiseptic, and sterile dressings. I change the dressing regularly and anytime it becomes damp or soiled, documenting all procedures meticulously. Monitoring for signs of infection is a key part of CVC care. I regularly assess the insertion site for any redness, swelling, or discharge, which could indicate infection. In addition, I monitor the patient for systemic signs of infection, such as fever, chills, or elevated white blood cell counts, which could suggest a catheter-related infection. In such cases, I immediately notify the healthcare team and collaborate on appropriate interventions, including ordering cultures, removing the catheter if necessary, and initiating antibiotics based on lab results. In terms of catheter patency, I routinely assess the CVC's functionality to ensure it is delivering medications and fluids effectively. This includes flushing the line with saline to prevent clot formation, using heparin locks when indicated, and ensuring that all lumens are working correctly. If I encounter resistance while flushing or if the line is sluggish, I assess for potential blockages or occlusions and take corrective action, such as contacting the physician for the possible use of thrombolytic agents. Another important responsibility is maintaining accurate fluid and medication management through the CVC. Many critically ill patients require multiple infusions, so I'm skilled in managing multilumen catheters to administer compatible medications and fluids simultaneously. I also ensure that medications requiring central administration, such as vasopressors, parenteral nutrition, or certain antibiotics, are delivered safely and accurately, adhering to the correct rates and protocols. In addition, I'm vigilant about preventing mechanical complications like catheter malposition, thrombosis, or air embolism. I monitor the CVC's external length to detect any displacement and check for changes in patient condition that could indicate complications, such as swelling in the extremities or signs of venous congestion, which may suggest a thrombosis. I also educate patients and their families on the importance of minimizing movement or pulling on the catheter to reduce the risk of dislodgement. In summary, my experience with central venous catheter care and management includes rigorous infection control, regular assessment of catheter function, safe medication administration, and collaboration with the healthcare team to address any complications. By maintaining these high standards, I ensure the safe and effective use of CVCs in the surgical ICU, contributing to better patient outcomes and minimizing risks. How do you assess and manage pain in surgical ICU patients? Assessing and managing pain in surgical ICU patients requires a careful, individualized approach due to the unique challenges these patients face, including postoperative pain, critical illness, and often limited ability to communicate. My approach combines both subjective and objective assessment methods, along with a multimodal pain management strategy tailored to each patient's needs. Pain assessment starts with recognizing that not all ICU patients can verbally express their pain due to intubation, sedation, or altered consciousness. For those who can communicate, I use standard pain scales, such as the Numeric Rating Scale, NRS, or the Visual Analog Scale, VAS, where patients rate their pain from 0 to 10. I encourage them to describe the type and location of the pain, as well as any aggravating or relieving factors. This helps guide decisions on the appropriate intervention. For patients who are nonverbal or unable to self-report, I rely on validated observational tools like the Critical Care Pain Observation Tool, CPOT, or the Behavioral Pain Scale, BPS. These scales assess behavioral and physiological indicators of pain, such as facial expressions, muscle tension, ventilator synchrony, and vital signs, e.g., changes in heart rate or blood pressure. By using these tools, I can systematically identify pain even in sedated or ventilated patients. Once pain is assessed, multimodal pain management is the cornerstone of my approach. This involves combining pharmacologic and non-pharmacologic methods to provide effective and safe pain relief while minimizing side effects. Pharmacologic management often begins with opioids, which are commonly used for moderate to severe postoperative pain. I administer opioids like fentanyl or morphine, titrating the dose carefully to balance pain relief with the risk of sedation, respiratory depression, or gastrointestinal side effects. In patients with high opioid tolerance or at risk for opioid-related complications, I work closely with the medical team to adjust dosing or switch to alternatives. I also use non-opioid analgesics, such as acetaminophen or NSAIDs, to reduce the overall opioid requirement and target different pain pathways. For specific cases, especially after certain surgeries, I incorporate regional anesthesia techniques like epidurals or nerve blocks, which can provide highly effective localized pain relief without systemic side effects. In addition to medications, I integrate non-pharmacologic interventions to support overall pain management. For example, I encourage early mobilization, appropriate positioning, and relaxation techniques whenever possible. These measures not only help alleviate discomfort but also promote faster recovery and reduce the risks of complications like deep vein thrombosis, DVT, or pneumonia. Regular reassessment is key to ensuring that pain management strategies remain effective and responsive to the patient's changing condition. I continuously evaluate the patient's pain levels and adjust the management plan as needed, whether that means modifying the medication dose, switching to a different analgesic, or incorporating additional non-drug interventions. I also remain vigilant for side effects, particularly in opioid use, and manage issues like constipation or respiratory depression proactively. Throughout this process, communication with the interdisciplinary team, including physicians, pharmacists, and physical therapists, is critical to aligning pain management with the overall care plan. I also involve the patient and their family in discussions about pain control, explaining the goals of therapy and addressing any concerns they may have. In summary, my approach to pain management in the surgical ICU involves thorough assessment using both verbal and behavioral tools, a multimodal strategy to optimize pain relief and minimize side effects, and ongoing reassessment to ensure that interventions remain effective as the patient's condition evolves. This approach ensures that pain is well controlled, improving both comfort and recovery outcomes for critically ill patients. What is your experience with postoperative care, including wound care, monitoring vital signs, and assisting with rehabilitation? I have significant experience in providing comprehensive postoperative care in the surgical ICU, where attention to detail and a multidisciplinary approach are essential to ensuring patient recovery. My work involves closely managing patients after major surgeries, with a focus on wound care, monitoring vital signs, and assisting in the early stages of rehabilitation. Postoperative wound care is a critical component of recovery, and I have managed a wide range of surgical wounds, from small incisions to complex, large-area wounds following procedures such as abdominal surgeries or trauma cases. My first priority in wound care is to prevent infection and promote healing. I follow strict aseptic techniques when changing dressings, ensuring that the wound remains clean, dry, and protected. Depending on the type of surgery, I use different dressing materials and techniques, such as negative pressure wound therapy, wound vacs, which can be particularly effective for large or deep wounds. In addition to the technical aspects of wound care, I also closely monitor for signs of infection or complications, such as increased redness, swelling, discharge, or delayed healing. I collaborate with the surgical team to address any concerns, such as the need for additional antibiotics or advanced wound care interventions. Patient education is also an important part of my role, ensuring that the patient and their family understand proper wound care at home once they transition from the ICU. In the immediate postoperative period, continuous monitoring of vital signs is essential to detect early signs of complications like hemorrhage, infection, or respiratory issues. I am well versed in interpreting vital signs, such as heart rate, blood pressure, respiratory rate, oxygen saturation, and temperature, within the context of a patient's post-surgical condition. For instance, a sudden drop in blood pressure or elevated heart rate could signal internal bleeding, while a spike in temperature may indicate the onset of an infection. In addition to routine monitoring, I often manage advanced monitoring systems, such as central venous pressure, CVP, lines or arterial lines, which provide more detailed information about a patient's hemodynamic status. This allows for early intervention, whether through fluid resuscitation, medication adjustments, or calling for urgent diagnostic tests or surgical review. By being vigilant and proactive, I help prevent complications and ensure that any changes in the patient's condition are addressed promptly. Postoperative rehabilitation is another crucial aspect of patient recovery, even in the ICU setting. Early mobilization, when appropriate, is vital for preventing complications like deep vein thrombosis, DVT, pneumonia, or muscle wasting. I work closely with the physical therapy and occupational therapy teams to ensure that patients begin safe, gradual movements as soon as their condition allows. For patients recovering from surgeries, particularly after prolonged immobilization or major procedures like orthopedic or thoracic surgeries, I assist in activities such as passive range of motion exercises, sitting up in bed, and eventually ambulating. Helping patients regain strength and mobility is important not only for their physical recovery but also for their mental well-being, as it fosters a sense of progress and control over their healing process. Throughout rehabilitation, I focus on managing pain and ensuring patient safety. This includes adjusting pain medications before physical therapy sessions and closely monitoring the patient for any signs of discomfort or instability. Additionally, I ensure that all lines, drains, and catheters are secured during movement to prevent accidental dislodgement. In providing postoperative care, I approach the patient holistically, addressing not only their physical needs but also their emotional and psychological well-being. I frequently educate patients and families about the recovery process, answering their questions and providing reassurance. Surgery and ICU care can be stressful, and helping patients understand what to expect during their recovery fosters confidence and helps reduce anxiety. In summary, my experience with postoperative care in the surgical ICU involves managing complex wound care, closely monitoring vital signs to detect early complications, and facilitating rehabilitation efforts. By combining clinical expertise, vigilant monitoring, and patient-centered care, I ensure that patients have the best possible chance for a smooth recovery and successful transition out of the ICU.